Welcome to the AHRQ Safety Program for Improving Antibiotic Use. This narrated presentation is titled, Approach to Patients Reporting Penicillin Allergies. The objectives of today's presentation are to discuss the potential harm associated with the overdiagnosis of penicillin allergies and to discuss the approach to evaluating penicillin allergies. Penicillin allergies are diagnosed in 10 to 20% of the U.S. population. However, less than 10% of patients self-identifying with penicillin allergy have positive penicillin skin tests. There are a number of reasons for the overdiagnosis of penicillin allergies. Viral exanthems are often misidentified as penicillin allergies because they occur at the same time that antibiotics are prescribed. Patients often are unable to recall the specific symptoms that led to the diagnosis, and then the diagnosis of a penicillin allergy is perpetuated in the medical records. Non-immunologic side effects such as nausea or diarrhea are often inaccurately identified as allergies. Another reason penicillin allergies are overreported is because other family members report penicillin allergies, and patients are told they probably have one too. However, penicillin allergies do not follow a clear inheritance pattern. A family history alone should not lead to avoidance of beta-lactams. Stewardship teams should partner with allergists whenever possible in developing approaches to accurately identify and confirm penicillin allergies. Even in the absence of on-site allergists, stewardship teams can develop approaches to reducing the proportion of patients inaccurately labeled with penicillin allergies. Clarifying penicillin allergy status can reduce the need for exposure to potentially less effective, more expensive, and occasionally harmful antibiotic alternatives. What is the harm in overdiagnosing penicillin allergies? There is increasing evidence that inaccurate penicillin allergy diagnosis results in negative repercussions. For example, patients with methicillin-susceptible Staphylococcus aureus or MSSA bacteremia reporting penicillin allergies are commonly prescribed vancomycin. However, patients with MSSA bacteremia have better outcomes if they receive beta-lactam agents rather than vancomycin. It has also been shown that patients with gram-negative bloodstream infections reporting penicillin allergies receiving non-beta-lactam regimens are more likely to experience treatment failure compared with patients receiving beta-lactams. Additionally, in a retrospective cohort including 8,385 patients who underwent 9,004 procedures, 11% of patients reported a penicillin allergy. Patients reporting a penicillin allergy had 50% increased odds of subsequent surgical site infections compared with patients not reporting penicillin allergies. This was attributable to receipt of second-line perioperative antibiotics. Clarification of penicillin allergies as part of routine preoperative care may decrease surgical site infection risk. A study including over 4,000 patients with hematologic malignancies who required antibiotic therapy indicated that patients who report beta-lactam allergies are more likely to remain in the hospital longer, have increased mortality, require readmission, and develop Clostridium difficile infection than patients not reporting these allergies. Another study in a cancer hospital indicated that 23% of patients reported penicillin allergies. These patients received on average more antibiotics than those not reporting allergies, had lower concordance with guideline recommended therapy, and were more likely to require hospital readmission. In addition to the increased likelihood of adverse patient outcomes associated with receiving non-beta-lactam antibiotics for hospitalized patients with infections, penicillin allergy labels increase healthcare costs for both individual patients as well as the healthcare system as a whole. One healthcare facility reduced antibiotic costs by 32% after developing a formal approach to evaluating penicillin allergies. Possible reactions to penicillins are often poorly documented in medical records. A benefit of electronic medical record systems is that allergies can be entered by most clinical providers, which is a benefit for patient safety. However, these allergies are often then unquestioned by future prescribers. Stewardship teams can take the lead in educating prescribers on the proper documentation of allergies. Intolerance to medication is often inaccurately recorded in the allergy section, leading to avoidance of penicillins. Almost 70% of allergies in the medical record lack documentation as to the nature and severity of the reaction. Sometimes there are major discrepancies between the reactions verbally reported by the patients and the documentation in the medical records. Even for patients who undergo penicillin testing, there can be issues. In one study, 36% of patients with negative penicillin skin testing had their penicillin allergy redocumented at a subsequent admission within 1 year without any evidence of an interval reaction. Obtaining a brief, focused history can be very helpful in determining the next steps. Questions you want to ask include: how long after beginning the antibiotic did the reaction occur? When asking this question, name the specific antibiotic that may have caused the reaction. Was there any wheezing or throat or mouth swelling that it developed? Did the patient develop urticaria or red, raised, itchy bumps that look like mosquito bites? If a rash occurred, what was the nature of the rash? Where was it and what did it look like? Was the patient on other medications at the time of the reaction? Since the reaction, has the patient ever received another penicillin or cephalosporin? Ask about specific brand names such as Augmentin or Keflex. If so, ask what happened after exposure to other beta-lactams. Remember to be as descriptive as possible and to document your findings in a place in the chart where they will be easily found. Considering the negative implications associated with reporting and recording allergies, it's important that we are able to characterize penicillin allergies appropriately. There are 4 types of immune-mediated reactions to be aware of. Type 1 are IgE-mediated or hypersensitivity reactions. They are mediated by the activation of mast cells after the drug exposure. In most cases, patients who develop type 1 reactions have had prior drug exposure or sensitization. Type 1 reactions generally manifest as urticarial, or the rapid development of irregular pruritic papules, or as angioedema, which is characterized by swelling of the face, extremities, or airways, and could lead to bronchospasm. Anaphylaxis is characterized by the rapid onset of urticaria as well as respiratory failure and hypotension. Type 1 reactions occur within minutes to hours of drug exposure. Type 2 reactions generally involve antibody-mediated destruction of white blood cells, red blood cells, or platelets. This type of reaction generally manifests with fatigue, jaundice, dark urine, or petechiae, but most commonly is detected on routine blood count testing. Type 3 reactions involve IgG immune complex deposition and complement activation. They generally manifest as serum sickness or vasculitis and present with palpable purpura, joint pain, urticaria, lymphadenopathy, and fevers. Finally, type 4 reactions result from the activation of T cells. They can range from relatively mild reactions such as maculopapular rashes to severe reactions such as Stevens-Johnson syndrome, toxic epidermal necrolysis, or drug rash with eosinophilia, and systemic symptoms or DRESS, which stands for drug reaction with eosinophilia and systemic symptoms. For any reaction that sounds like it could be a type 1 IgE-mediated hypersensitivity reaction, consider penicillin skin testing if available in your facility. Patients who have positive tests can be considered for desensitization. A negative test is useful in ruling out a type 1 reaction, but does not help with diagnosis of non-type 1 reactions, including severe non-IgE-mediated reactions such as Stevens-Johnson syndrome or DRESS. In addition, desensitization is not effective for non-type 1 reactions. So again, penicillin testing is used to determine the likelihood of type 1 reactions. Penicillin is the only antibiotic with a commercially available skin test in the United States. Historically, penicillin skin testing consisted of a skin prick and intradermal testing using both the major determinant penicilloyl polylysine, which is commercially available in the United States as PrePen, and minor determinants with the positive histamine and saline controls. Some of the minor determinants are not available in the United States. An alternative approach that has been pursued includes using penicilloyl polylysine and penicillin G for skin testing, followed by oral amoxicillin challenge in cases where the skin test is negative. If at any point a part of the test is positive, further testing is terminated. Penicillin skin testing should be delayed if a patient received an antihistamine medication within 4 days. The process of skin testing begins with introducing the reagents via skin prick, and if negative, these same reagents are introduced by intradermal injection. If either of these steps elicits a reaction defined as a wheal with a zone of erythema at least 3 millimeters in diameter, and the saline control is negative, this test is considered positive. If the positive histamine control is negative, or the negative saline control is positive, the test is considered indeterminate and should be repeated at a later time. If the skin prick is negative, 0.02 milliliters of each reagent is administered intradermally, and the patient is observed for 15 minutes with the same interpretive criteria used as with the skin prick. If both approaches to skin testing are negative, a single dose of 500 milligrams of oral amoxicillin is administered, and the patient should be observed for 60 minutes for a reaction. The rate of resensitization in skin test negative individuals following 3 courses of penicillin was found to be negligible, indicating that patients cleared of penicillin allergies do not carry an increased future risk compared to the general population. When done correctly, penicillin skin testing is highly predictive of serious anaphylactic reactions. In the U.S., penicillin testing has a negative predictive value of about 98%. Rarely, skin test negative patients may get mild hives and itching following penicillin administration, but these resolve with continued treatment. Because skin testing evaluated only the possibility of type 1 reaction, it cannot exclude the presence of another type of reaction, such as gastrointestinal reactions, drug fever, or Stevens-Johnson syndrome. IgE-mediated penicillin hypersensitivity decreases with time, with over half of skin test positive patients losing sensitivity by 5 years and 80% by 10 years. For patients with IgE-mediated penicillin allergies, it's important to be aware of the likelihood of cross-reactivity to other beta-lactams. Cross-reactivity between penicillin and aminopenicillins like amoxicillin is high at approximately 95%. Cross-reactivity between penicillin and other beta-lactams is much lower. Newer data suggests that these percentages are approximately 5% for first-generation cephalosporins, 2% for third and fourth generation cephalosporins, and 10% for carbapenems. Cross-reactivity between penicillin and aztreonam is not observed. Fluoroquinolones are other agents to consider when appropriate for patients with serious penicillin allergies. The Stewardship team can take a number of approaches to improve the accurate labeling of penicillin allergies. Incorporate recommendations for penicillin allergies in local guidelines to ensure acceptable second-line options are being prescribed. Nurses should be educated by the Stewardship team about questions they should ask regarding penicillin allergies during their initial encounter with patients. Consider a system for a soft entry of reported penicillin allergies in the medical record that needs to be confirmed by another provider before it becomes a hard entry to avoid unnecessary and permanent labeling. Ensure a system is in place to remove inaccurate penicillin allergy labels from medical records. Throughout the AHRQ safety program for improving antibiotic use resources, we describe treatment options for patients with serious penicillin allergies. Education of patients and providers is key to retain allergy delabeling. We must continue to educate prescribers on how to effectively ask their patients about reported penicillin allergies. Conduct targeted education of patients with reported penicillin allergies. For minors or patients with impaired cognition, ensure that family members are aware of the significance of any findings. Consider initial screening of reported penicillin allergies by pharmacists. Pharmacists can be very effective in allergy screening as they are well versed in antibiotic-associated adverse events and experienced in acquiring medication history, and they routinely educate patients about medication safety. In facilities with allergists on site, consider automatic allergy consultations for patients with reported penicillin allergies. Some facilities have implemented inpatient penicillin testing with infectious diseases clinicians or pharmacists using protocols developed in conjunction with allergists. Electronic health records, or EHRs, can assist with the rapid identification of patients with penicillin allergies. An observational study of hospital-performed penicillin skin testing found passive recommendations in the chart alone to be ineffective, with nearly half of patients with negative penicillin skin testing still carrying the label of penicillin allergy at discharge. In an EHR-based environment, active removal of the patient's allergy, clear documentation of test results, and counseling should be the minimum standard of care post-procedure. In one 870-bed facility, a clinical pharmacist ran a penicillin allergy service under the supervision of an allergist. The incidence of penicillin allergies reported in this facility was 8%. The general protocol for the pharmacist was as follows. The pharmacist received a daily report of inpatients with reported penicillin allergies. The pharmacist then utilized an algorithm to identify patients who would benefit most from allergy delabeling, such as patients actively receiving broad-spectrum agents, immunocompromised patients at an increased risk of requiring antibiotics in the future, and patients with no active discharge order. The pharmacist conducted interviews using standardized questionnaires and removed the allergy label when possible. The pharmacist then conducted skin testing for possible IgE-mediated reactions and documented results of penicillin skin testing in the chart. If skin testing was negative, the penicillin allergy label was removed. The pharmacist educated prescribers as well as patients and family members of the significance of the results. Using this protocol, 98% of patients were cleared of penicillin allergy labels, and significant reductions in the use of vancomycin, carbapenems, and fluoroquinolones were observed. In summary, receiving non-beta-lactam agents is associated with poorer outcomes for patients with active infections reporting penicillin allergies. Performing a careful history can often identify non-allergic reactions. Removal of allergy labels from the medical record when they do not represent real allergies is essential to optimizing patient care. Penicillin skin testing is an effective way to exclude IgE-mediated allergies and can be safely implemented in different healthcare settings with varied availability of resources. Disclaimer: the findings and recommendations in this narrated presentation are those of the authors, who are responsible for its content, and do not necessarily represent the views of AHRQ. No statement in this narrated presentation should be construed as an official position of AHRQ or of the United States Department of Health and Human Services. Any practice described in this narrated presentation must be applied by healthcare practitioners in accordance with professional judgment and standards of care in regard to the unique circumstances that may apply in each situation they encounter. Use of brand, manufacturer, or vendor names is for identification only and does not imply endorsement by the Agency for Healthcare Research and Quality or the U.S. Department of Health and Human Services.